Well, I have only.
She is happy that you are at home.
No.
Yeah.
Into his mom that at least Baba is at home.
Oh, I see.
No, it is correct, sir.
Happy.
Wife is happy to stay in the home. It's correct.
Your wife is happy, na?
Happy, sir.
That's very good news.
But without phone, sir.
So we can start now, sir.
Yeah.
Dear participants, respected expert panelists, especially Professor Daniel Chim, welcome to Bangladesh. Thank you, sir. I think we are very grateful to you for your kind consent. For the all the panelists are very well known to you, but for the junior fellows, I just few introduction for you. Thank you, sir. We can. Professor Dr. Daniel Chim is very much popular in Bangladesh, but I pay tribute to a living legend. His early years, he did MBBS and MMed for the National University of Singapore in 1987. He did Masters of Medicine in Internal Medicine and membership Royal College of Physicians, United Kingdom in 1992, and Master of Medicine in Internal Medicine, and now he's Director of National University Center, Singapore, Senior Consultant Cardiologist at the same hospital, National University Hospital, and he's a Professor of Medicine, School of Medicine, National University of Singapore. He's lots of experience, I think, in South Asia. He did Fellowship of American Cardiology 2001, Fellowship of Society of Coronary Angiography of Intervention 2002, Fellowship of Royal College of Physicians in 2004, training in vascular ultrasonography at St. Vincent Hospital, Sydney, Australia, carotid stenting at National Taiwan University, Taipei, Taiwan. He's an extraordinary organizer. Everybody will know. He's a great organizer, a chairman of Singapore Heart Foundation, past president Singapore Cardiac Society, immediate past president of Asia Pacific Society of Interventional Cardiology, APSIC, founding member of Asia Interventional Cardiology Therapeutics. He's a great clinical researcher, teacher, and faculty. Professor Tan is an active clinical researcher. He is regularly invited lecturer and faculty in many international cardiology meetings. We know everybody. He's a visiting professor in China and University of Mandalay and Myanmar. A great human being. Like me, I'm very much fan of Professor Tan. Lots of Bangladeshi fellows, faculties, he loves Tan because he's a great human being. He's a great clinician, teachers, and cardiologist, but above all, he's a great human being. IPDI wishes his healthy and long life. Welcome, Mr. Tan in Bangladesh. Thank you, sir. Professor Abdul Wadud, sir, please introduce him, our faculties, sir. Lots of faculties, please introduce him.
Professor Tan, I think you know most of our faculties. My teacher, Professor Abdullah Al-Shafi Majumdar, who is the General Secretary of Bangladesh Cardiac Society, and he's ex-director of National Institute. Professor Afjalur Rahman, he's also an ex-director of NSABT. Professor Mamunur Rashid, as professor in NSABT. There is also Kaisa Nasrullah Khan, both of them are working in two renowned private hospitals, and many others. Professor Shahabuddin, he is the head of the Department of Select Medical College. Many other faculties are there, and some other are waiting to, they'll be joining shortly because everybody actually could not finish their work in time. So, Professor Tanhichi, we are really grateful that you have consented to give a lecture to us, and the subject is very important for the fellows. And if they have a good grounding in what to do, particularly in a complex case like bifurcation lesion, that will be very helpful when they become very active. COVID is not going to stay for long, and they have to go back to the cath lab and provide good service to the patient. To that end, I hope your lecture will do a great service. I now ask you to start your lecture. Thank you, sir.
Thank you very much, Professor Chaudhary, for the very kind introduction, and also Dr. Mosid Ahmad for making this possible. It's an honor and pleasure for me to be involved in this interactive professional development initiative. Always been devoting myself to education of the younger doctors. I'm just glad to be able to share this with our Bangladeshi colleagues as well. So the topic that has been assigned to me is this step-by-step manual for planning and management of bifurcation lesions. So what is coronary bifurcation? It refers to a lesion that occurs at or near a division of a major coronary artery. And that coronary bifurcation is characterized by three important anatomical segments: a proximal main vessel, a distal main vessels, and a side branch. And along that, you can see that
Please, everybody mute.
So the thing about bifurcation lesion is that pathological studies have shown that the arterial branch points are foci of low shear and low flow velocity, and these sites are predisposed to the development of atherosclerotic plaque, thrombosis, and inflammation. And so the bifurcation PCI is considered a complex and a high-risk lesion. It accounts for 15 to 20% of PCI. There is considerable variations in the anatomy of the various bifurcation lesions, particularly important in left main bifurcation lesion. The plaque burden and location of plaque is highly varied, and the angle between main vessel and side branch are also very varied. And then we know that in the course of intervention, dynamic changes in the anatomy can occur. Plaque shift may happen, dissections can occur as well. And oftentimes in the intervention for bifurcation lesions, we have difficulty in achieving a perfect lumen reconstruction. There's either incomplete coverage of the ostium, and also all this result in an increased risk of restenosis. So no two bifurcations are identical. And so an appropriate strategy from the very outset is important, and it helps to save life and to minimize complications. So this is the evolution of bifurcations PCIs for many of us who have been around for a long time. In the early days, there's not much option except for kissing balloon inflation. And we started off with bare metal stents in the early 1990s, going on to a DES in the early 21st century, going on to a second generation DES and so forth. Along the way, we come up with techniques of GuideWire, provisional side branch stenting, port, final kissing, and DK crush, which has been around since 2010. So it's been about 2004. So it's been about 16 years since they've been doing this DK crush. So I think many of us know about this many classifications. There's so many classifications that we had to deal with in the very beginning. But I think most of us have now settled with this Medina classification. And Medina classifications basically codes three numbers. The first number refers to a proximal main branch. Second number refers to the state in the distal main branch. And the third number refers to the side branch. And it gives a number to either 1, which indicates the presence of stenosis, significant stenosis, or 0 for the absence of stenosis. So you get the three numbers. A typical true bifurcation will be a 1-1-1, where you have narrowing in the main proximal vessel, distal main vessel, and the side branch. However, all the classifications have a problem. The classifications depends only on angiogram. And we know that the angiogram is very poor in terms of telling you for sure how the plaques are being distributed and the extent of the disease. Oftentimes, you will need imaging to gather this sort of information. And this classification, which includes Medina classification, does not really take into account what happens to a side branch when you dilate the main branch. It doesn't have this predictive ability to tell you whether it is safe to safe for the side branch or not. So in a intervention of a bifurcation lesion, I think there are unique challenges. And so these are some of the challenges that we encounter. We will have to deal with a vessel shape and sizing. So there could be a discrepancy in the diameter between the proximal as well as the distal vessels. There are procedural complications that we have to deal with. Plug shift that can cause a closure of the side branch, dissection, perforation, and sometimes even movement of the artery and during cardiac contractions can also make the procedure highly challenging. There's considerable variations in the bifurcations and lesion anatomy, as I've mentioned: side branch patency, part distribution, lesion composition, angle between main branch and side branch, and the locations of the affected vessel. These are the other multiple challenges in bifurcation PCI, which are broadly classified into two: clinical anatomical variations and procedural options as well. So just imagine you have to think about all this stuff as you consider your strategy, and you have to think of all these possible strategies that you can undertake in doing a PCI for this bifurcation lesion. So I think the approach to bifurcations PCI for particularly the junior doctors is that most of us would adopt what we call a provisional approach, and it is the most recommended approach. And the approach here is really dictated by the side branch. We need to know whether this is a true or not a true bifurcation. What is the size of the side branch, the extent and distribution of disease in the side branch, how important the side branch is for the patient and for that specific anatomy, and the angle from the side branch. So I think the provisional approach versus two-stent approach has been tested in many earlier randomized controlled trials. And so if you can see on the left side here, these are the various trials that compare a provisional approach versus a two-stent or systematic two-stent bifurcation stenting approach. And when you look at the primary endpoint, actually most of them has got no significant difference whether you do a provisional or two-stent. In fact, BBC One suggests that maybe a provisional approach is a safer option compared to a two-stent bifurcation strategy. When we follow up Nordic and BBC trial for up to 5 years, in fact, you can see that the provisional approach seems to have a lower long-term mortality than the systematic dual stenting technique. But is this correct? But you must remember that this is still a very old data that we are looking at, and old techniques and so forth. So just looking at individual trials is not good enough. Let's look at meta-analysis of 5 randomized controlled trials, 7 observational studies, nearly 7,000 patients, and look at provisional versus two-stent strategy. And you find that actually provisional strategy seems to be safer with regard to DES, thrombosis, and myocardial infarction. There were lower incidence of thrombosis and myocardial infarction when you use a single stent strategy. But this is one meta-analysis, because when you compare another meta-analysis of another group of trials and patients, you find that in this study, two-stent strategies are just as good in terms of target lesion revascularization and stent thrombosis and myocardial infarction and side branch restenosis. So the verdict is really not out here. We don't know whether provisional is really that good and so forth. But I think as far as clinicians are concerned, when you encounter a bifurcation lesion, there are only 3 choices that you have to decide. One is to just keep the side branch open and do nothing about it, just maintain it open. 2 is to do a provisional stent. In case the side branch gets into problem, then I deal with it. Otherwise, I leave it alone. 3 is to go straight for a two-stent strategy. So these are the basic 3 choices that we have to make. I think in the first strategy of just keeping the side branch open, this will be the situations when you have a side branch that is small, that has got osteo or diffuse disease, and is clinically not relevant. So we just simply want to keep the side branch open, and we have no intention of putting stent or something or anything else more aggressive in this sort of situation. So the techniques really is quite simple. You just put the wire in both the branches, then you dilate the main vessel, and then after that you stent the main vessel and you leave the wire in the side branch, and you post-dilate the main vessel stent, and then with the side gel wire inside in the side branch. Most of the time, there's no problem in pulling back the side wire from the side branch, and then you just simply keep the side branch open with this side branch wire. Provisional stenting is the next strategy. In provisional stenting, we use it when patient has perhaps a side branch that has minimal disease or only at the ostium, and when the side branch is suitable for stenting. So the technique here is you insert a wire into each of the main vessel and the side branches. Then you stent the main vessel with a diameter selected according to the distal main diameter. Then afterward that you do a proximal optimization technique where you dilate the proximal part of the stent. And then you do a GuideWire exchange. So you can actually take out your gel wire, and then or you can take your main wire and then put it into the side branch, or you can take a new wire and go into the side branch. And then you remove the gel wire carefully to avoid abrupt guiding catheter intubation. So you pull the wire, the guide catheter may be sucked in, and then finally you do a kissing balloon inflation if you decide you want to do a kissing balloon inflations. Otherwise, the procedure pretty much ends with this provisional stenting approach. So some people want to do a routine kissing balloon inflations after stenting of the main vessel. Many of us do not necessarily do so. So provisional stenting has got advantages. It is very simple and it's very fast. It's got excellent short-term and long-term results, as I said before. It's got perhaps in their meta-analysis suggested a better long-term mortality even. It reserves all other options. So I can still do a two-stent strategy if my provisional stenting approach fail. And more than 60% of our patients, even with the big bifurcations of the left main bifurcation, as we call it, can be treated using the provisional technique. So what are the lesions that we will select to do a provisional approach? I think most of us will favor insignificant stenosis at the ostium circumflex when you have a Medina classification of 110 or 100. You have a small circumflex of less than 2.5 millimeter. You have a diminutive circumflex, which you don't really want to intervene too much. When you have a very wide angle between circumflex and LAD, and you have no concomitant disease or only focal disease in circumflex. So all these lesions would favor a provisional stent approach. Now, when we do bifurcations PCI, we have to consider the difference in terms of the diameter of the main vessels versus the distal vessels and the side branches. In general, we all know from the Finney's law or the Murray's law or whatever law that you come to know about, the main vessel is always going to be larger than the individual side branches, and the main vessel is typically two-thirds the size of the sum of the diameter in the two daughter vessels. So two-thirds, so this must be always larger in an individually too, and two-thirds of the size. And this is important because we oftentimes will encourage people to do proximal optimization techniques for the reasons that you want to achieve good appositions in the vessel, particularly in the main vessel. So when you do a port after putting a stent across a bifurcation lesions, while your distal parts may be well expanded, the proximal part is severely underexpanded. This is where you do take a larger size balloon and you do a balloon inflation in the main vessel in an attempt to fulfill the Murray's law criteria, as we know that the main vessel is going to be larger. At the same time, it allows the reconstruction of the initial physiologic anatomy of the bifurcation. And by doing a port, it allows your wire to go in and out of the side branch quite easily. So why do we do port? We do it to correct any under-expansions in the proximal vessel. You restore the proximal main vessel circularity. You facilitate the side branch rewiring, and you scaffold the side branch ostium with this port technique. Now, just a little bit on the ports technique here. This is a technique that where you would actually put the distal marker just proximal to the carina. So take a short non-compliant balloon, put the distal marker at the carina so that you won't go too far off and go too distally and cause a rupture of the daughter vessel. All right. And so when you want to, after port and you want to access the side branch again, you will always direct the side branch through the distal strut of the stent in the main vessel. Now, this GuideWire exchange where you want to access whether proximally or distally is quite important. Because if you access a patient's, if you access the stent cells which are proximal in the location, you find that you actually create a new carina in the dorsal vessel. If you go by the distal cells, you actually provide a scaffold of the side branch, which is much better, which is much in terms of rheologic, the blood flow, compared to if you go by the proximal stenting. So for all intents and purposes, most of the time we will recommend going by distal cell, except for DK crush technique, which we'll talk about afterwards. So kissing balloon is another important part of our bifurcations PCI. We do kissing balloon basically to modify the geometry of the implanted stent. We want to improve the expansions in the proximal main vessel. You want to improve also the results in the side branch. Typically, we do use two non-compliant balloon, and the size of which will be sized to the distal vessel and not the proximal vessel. But you can always have a short proximal overlap in putting the two balloons into the main vessel here. All right, so this is kissing balloon inflation. Most of the time, again, we will do what we call a two-step kissing balloon inflations. That means I inflate the balloon one time at high pressure, come down, inflate the balloon a second time, high pressure, come down in the side branch, and then both going up at a nominal pressure at the same time. So this is what we call a two-step kissing balloon inflation, instead of just doing both, inflating both at the same time in what we call a one-step kissing balloon inflation. Some people don't like to do kissing balloon inflation. Then you can do what we call a POT, side branch and POT technique, which is an alternative. Meaning to say that what we do here is trying to achieve the same thing as a kissing balloon inflation. You want to optimize the final result of a provisional bifurcation stenting. You want to maintain a circular geometry. You reduce a side branch ostium obstruction and reduce the risk of a side branch occlusion. So what do I mean by POT, side branch POT? Meaning to say that you put a stent in the main vessel, you do a POT, then you put a wire into the side branch, then you do another side branch dilatation, and then you take out the balloon, and then you finish with another POT. So in this case, then you don't have to do a full balloon inflation at the same time. So this is another technique that you can consider if you don't want to do a POT technique. Now, provisional approach has got situations in some cases where you might have to go on to put in a second stent, as in a build-out or a rescue two-stent strategy. It all depends on the series that you are looking at. If you look at the Colombo study, 30% of his cases go on to do a two-stent strategy. But if you look at Pan and Stegen, you find that the crossover is actually very low in provisional strategy that was decided right from the very beginning. So when do we consider putting a stent into the side branch in a provisional approach? I think all of us will agree that when you have a significant side branch flow impairment, which is TIMI of rate of less than 3, we will consider some kind of rescue stenting if the side branch is large enough. In the presence of a major side branch dissection where you worry about acute abrupt closure, when the side branch is diseased and large enough to lead to significant residual ischemia after stenting of the main vessel, and where future access towards the side branch may be important to the patient, then you might consider a side branch stenting. So when you decided on a side branch stenting after putting a stent in the main vessel, you are basically, you still have 3 options in terms of bifurcation techniques. You can do a tap technique, you can do a reverse crush technique, or you can still do a Culotte technique. And all of them have their own respective advantages and disadvantages, which I'll talk about again later on. But this will have been the build-up two-stent strategy. Now, the third choices in the bifurcation PCI is a two-stent strategy, where from the very outset, you have decided that you want to do two-stent strategy. And two-stent bifurcation technique occurs in between 15 to 30% again of our bifurcations PCI. And it's usually considered when the side branch is large, with more than 50% stenosis extending more than 5 millimeter beyond the side branch osteum. And typically, the technique that we use is often one where the side branch will be stented first and then followed by the main branch in the culotte and so forth. So that will be the technique that most of us would use first. So deciding which two-stent approach, you can roughly use this table for your own purpose. Now, first of all, when you look at the anatomy, you ask yourself, are you comfortable and confident in rewiring the side branch after putting a stent in the main branch? If you're not confident of rewiring the side branch, then maybe you just go straight to a DK crush. If you're confident of doing crossing the side branch after a main branch stenting, then look at the anatomy first. Look at the angle between the two daughter vessels. If the angle is more than 70 degrees, you can try a T-Stent or a tap technique. But if the angle is less than 70 degrees, then you want to ask yourself again, is the main vessel and the side branch are of the similar size? If the main vessel and the daughter vessels are of different sizes, then perhaps a DK crush or a tap technique is better. But if the daughter vessels are about the same size as the main parent vessel, then you can do a tap or a DK crush or culotte stent technique. So when you have a large discrepancy in the size of the main vessels and the daughter vessels, culotte is really not a good choice in that sort of situations. So let's look at this table, and you can see culotte is good when your side branch is about the same as the diameter of the main vessel, and the angle should not be too wide. The best is less than 55 degrees, and you can actually do a provisional approach with the culotte stent technique. But for DK crush and for SKS, simultaneous kissing balloon inflation stenting technique, you find that there is no provisional approach. You have to just put in the two stents right away. When the angle is less than 90 degrees, you can use DK crush in any sort of bifurcations anatomy. But if the angle is about 90 degrees, then perhaps a T-Stent or a tap technique is more applicable. So my strategy here is that as an operator, you should know at least one or two types of two-stent bifurcation techniques. And I always think that it's going to be anatomy driven. So if the angle is more than 70 degrees here between the two daughter vessels, you can consider a tap technique, which is what I will do. If the angle is less than 70 degrees, then I will do what I call a culotte or a crush or DK crush technique. So let's look at the T-Stenting strategy here. So when we do T-Stenting strategy, you basically put your stent in the main vessel, and then you maintain the wire in the side branch. And then after that, you cross into, once you put in the main vessel, you go into the side branch, you balloon, redilate, and then you put in your second stent, what we call a T-Stent technique. So it's used to optimize the side branch stenting. And there is a modified version of T-Stenting called the tap technique, and that you will want to access the side branch through a distal strut. So I want to say that T-Stenting strategy, while it is actually a good strategy, one of the biggest problem is that when you put the branch, a stent in the side branch, very often you may have a situation where you just about miss the ostium of the side branch, which can be a site of a focal restenosis, as in this particular case that is illustrated. So then people come out with a better strategy to avoid this missing covering of the ostium of the side branch, is what we call a tap technique. So what is a tap technique? The tap technique here is described by Dr. Guan from Korea, is that first of all, you put a stent in the main branch with a side branch that is jailed in the side branch, with a guide wire that is jailed in the side branch. Then after you perform, put in a stent, you can do a kissing balloon inflation first, or you can just simply take a balloon and just open up the side branch. Then you will put your stent in the side branch with a little bit of protrusion into the main vessel. So that's why TAP is called a T-Stenting and small protrusion. You will inflate the stent and then together with the a balloon that is inflated in the main vessel. So you find that after that, you can just move out everything. So it's actually a very simple technique here. Just simply put the stent in the side branch, do a simultaneous balloon inflation in the main vessel as well in the side branch, and you're done with the procedure. The thing about TAP is that people worry about that protruding part, whether you'll be crushed, whether it will be deformed and so forth. This is a bench testing that tell us that the kissing balloon post-dilatation does not crush the side branch stenting technique. And so TAP technique is something that is very popular in Europe. So they don't like DK crush and they prefer TAP technique. Let's look at Culotte technique. Again, Culotte is something that is very familiar to many of us. First of all, you will dilate both branches. Then you put the stent into the more angulated side branch first. And once you put in the stent, then you withdraw the wire and pass it to the other main vessel, do a balloon pre-dilatation, and then put in your second stent. And then at the end of which, you will cross the wire again with the first into the first stent, and you do a kissing balloon inflation to finish the procedure. So Culotte was first described by Chevalier and way back in 1998, so that's a long, long time ago. So the advantage of Culotte is that it allows adequate osteo coverage both in the primary two-stent strategy and also as a provisional technique. So the thing about a Culotte is that proximal vessel, which is the parent vessel, have double layered sleeve of stent. This is the biggest contrast to DK crush, where you only have a multi-layer of stent on one side of the vessel, on not the entire sleeve of the parent vessel. Both the proximal end of the main branch and the side branch stents will need to be sized up to the proximal vessel. That's why the discrepancy cannot be too large. And both main branch and side branch, as I said, need to be similar in diameter. And you want to have a stent design that have a cell space that can be expanded to the size and diameter of the side branch. So this is a illustration of a patient with 111 Medina classification. So you can see that there is actually very tight lesions at the distal lamina and the osteo of the LAD and circumflex artery. And this is the spider view. Again, you can see that there is a severe stenosis, a true 111 lesion. What you do is you put a stent into the side branch first. And then this is a very important technique. As you pull back your wire from your side branch and direct it to the distal cell into the other main vessel, you want to make sure that you don't pull the wire out of the stent. So you know for sure that your stent, your wire is always within the stent in the proximal segment. All right. So now you direct into the main vessel, you do a balloon pre-dilatation, you put in your second stent, and then you do what we call a two-step kissing balloon inflation, dilate the main vessel, dilate the side branch, go up together, and then you finish with a port if necessary. So this is the final angiography in this patient who had a Culotte stent technique. And this is the IVUS study telling you that the stent is fully expanded in the post, and you find that there is a very round shape, so suggesting that there's very little asymmetry that we are looking at here. So the Culotte stent technique has got an advantage, is that it provides a near perfect coverage of the side branch ostium. The disadvantage is that it has got a high concentration of metal with double stent layer at the carina and in the proximal part of the bifurcation. You require rewiring of both branches, and you need both stents to accommodate the potential diameter mismatch. Let's talk about DK crush. DK crush has become quite well known in recent years. DK crush is a 7-step procedure according to Dr. Chen Shaoliang. First, you involve a side branch stenting, then you take the balloon and crush it, balloon in the main vessel to crush it, and then you do your first kissing balloon inflation, then you do your main vessel stenting, you do a port, then you do a second kissing balloon inflation, that's why it's called a double kissing, and then you do a final report. So this is a 7-step procedure. But the Dr. Chen from China, Nanjing, will tell you that DK crush is best supported with a 3 steps of IVUS or OCT imaging. Let me tell you, show you again one case. This is a patient with a clearly a 111 sort of a distal left main bifurcation lesion. After you have wired both lesions and pre-deal the lesion, you would suggest that we do a first IVUS to see. Firstly, to evaluate the pre-dilatation results. Then you want to size this side branch. You want to size the main branch. Notice where are the healthy landing zone, whether it's in the proximal or in the distal, and then you want to size the port balloon for the parent vessel. So this will be the typical images that you will get from a first IVUS imaging after pre-dilating both the side branches. So having done the imaging, you will put your first stent into the main vessel here. So he took a long stent, and then after that he took a balloon to which is sized to the LAD vessel to crush the stent. And then after that, you will take an even larger balloon to crush the proximal part of the stent within the left main itself. So this is important here. So you optimize the complete crushing of the stent in the left main. Now, you have not taken out the wire because he will say that you will leave the wire here and then pass a third wire using this wire as a guide so that you know for sure you are in the proximal cell. And he will recommend doing a proximal cell entry into the side branch. Once you have done your recrossing with a third guide wire, you will do your second IVUS. You will use it to evaluate the crush segment. You will want to see your position of the wire, and you want to plan for main vessel stenting. And so this is what he will be getting at in the information. So from the IVUS, you will be able to tell that the wire is in the proximal part of the cells. And so this is in the ideal position in a DK crush technique. So the reason why we always use a main proximal cell instead of a distal cell as we would use in most of the other bifurcation PCI is that in this bench study that we did together, you find that if you cross in the proximal cell, there's actually very little gap in the carina area. But if you go by a distal cell, we can actually have a residual gap in the carinal area using a DK crush technique. And so that's why the recommendation is always to go by a proximal cell. So this, after crossing, we will do our first kissing balloon inflation. And so this is pretty straightforward. Once you've done your kissing balloon inflation, you're ready to put in your second stent into the main vessel. And so you put a stent first, and this will be the stent results. And after which, we will always port it again in the main vessel. So you will port it in the main vessel, and this is the result. After you have done this, you will now have to recross into the side branch to do your second kissing. But in this case now, you would have to pull up your side branch wire first, and then before you do your stenting in the main vessel. So this is a two-step kissing balloon inflation here and here. And then we finish with a port, and this is the final results. So then you should end your procedure with a third IVUS to look for your optimal stent expansion. Any malapposition, make sure there's no edge stenosis, there's full lesion coverage, and there's no edge dissection. And so this will be the final IVUS findings, and this will be the angiogram after a DK crush technique. So this is 1 year follow-up after DK crush, still looking very good. So the DK crush technique advantage is that it's a very effective technique, very effective for large dominant disease circumflex, definitely better than the classic crush, because in classic crush, 10% of the lesions you can't cross into the side branch after crushing with a stent in the main vessel. The disadvantage is that it cannot be performed as a provisional strategy. There are multiple steps involved, and few operators may have the experience. So the outcome as far as DK crush and Culotte stent technique is that we know that from a DK crush 3, looking at these two different techniques in patients with left main bifurcation, DK crush was superior to Culotte stent technique. And the reason why it may be superior is because of this residual Neckim rings that we see in patients with a Culotte stent technique. In the DK crush, there's no napkin ring residual, but in the culotte, you can see this napkin ring. Whether this is the reasons for the adverse outcomes, we don't know, but this is something of interest. But for sure, nowadays, when we decide whether we want to do one stent or two stent strategy, we can actually predict based on this definition trial. Definition trial has got a criteria that will tell us whether the lesion that you are dealing with is considered a simple bifurcation or a complex bifurcation. And you would define somebody as having a complex bifurcation if you have one of these major criteria plus two other minor criteria. So these two other minor criteria can be in any of the following. It could be the mean vessel length of lesions, it could be presence of thrombus, multiple lesion, and so forth. So by looking at this criteria and testing it out in what we call the definition 2 trial, which was presented at EuroPCR eCourse this year, clearly a use of a two-stent strategy was superior to a provisional strategy when you are dealing with complex bifurcation lesion with regard to clinical endpoints of reduced target lesion revascularization and target lesion failure at 1 year. So now we can actually, instead of just eyeballing, we have objective criteria where we can rely on to ascertain whether a bifurcation lesion is indeed complex or simple. I want to end on by just commenting a little bit on the imaging guidance. I think IVUS or OCT will be very helpful in any form of bifurcations PCI, and that they will provide a better insight into the part configurations, which may actually help you to decide whether to do a two-stent or a single-stent strategy. And it will help to improve outcomes for sure and allow a selection of an appropriate stenting strategy. And certainly, it will also help in terms of aiding the vessel sizing and identify calcifications where you might consider atherectomy. In fact, the use of IVUS has been shown to even have a mortality benefit in the left main PCI, as in the reports published by Park from Korea. So IVUS is certainly something that you will encourage in doing a complex bifurcations PCI, particularly involving the left main. The other thing about FFR, which I want to touch on here, is that oftentimes when you do a provisional stent strategy, you might find that there is a plug shift or choroidal shift, which causes a narrowing of the ostium in the side branch. And Kuhn did a very important study to tell us that when you have a side branch osteal lesions of more than 75% stenosis, actually 2/3 of them are physiologically not significant. That means only 1/3 of patients actually do you have to worry about whether there's ischemia going on and so forth. So for the most part, if the patient has got no symptom, has got no angina, no ECG changes, and the blood flow is good, I would just leave the side branch alone if I've already decided on a provisional stenting strategy. And certainly when you use FFR, it has been to decide whether to leave the side branch alone and consider a provisional approach or deferred strategy and so forth. It has been validated in at least 4 clinical trials. So FFR guided revascularizations can be safely applied to patients with bifurcations or left main stenosis. And we know that these bifurcations lesions can be assessed quite accurately if there's no downstream significant stenosis. IFR has not been used to evaluate a bifurcation lesion at this point in time. So in conclusion, Mr. Chairman and everybody, all my friends here, I think the goal of PCI in bifurcation lesion is to attain optimal results in the main vessel and to maintain the physiologic patency of the side branch. The planning of the strategy upfront is critical, and knowledge of all possible BOR techniques must be kept in mind. You must have at least two stent strategy up in your sleeve as you consider complex bifurcation PCI. So while the provisional side branch stenting should be the default strategy for low-risk bifurcation, a two-stent technique may be preferable for high-risk or true bifurcations. Although evidence is lacking as to the superiority of one two-stent technique versus other, I personally feel it is unlikely that any single two-stent technique will be superior in all bifurcation morphology. Depending on your own preference, DK crush technique seems to be the most favored, but tap technique and Culotte techniques are also excellent options, in my opinion. The decision as to which two-stem strategy to use should be driven by the bifurcation morphology, the operator experience, and the clinical trial data. And finally, employing imaging as well as physiologic assessment plus atherectomy to save time and optimize the count will be something that I would highly encourage. Thank you very much for your attention.
Thank you, sir. Thank you, sir. Excellent presentation, sir. I think all the panelists and participants enjoyed it. This you lecture in the archive, in the IPD archive. I think all the junior fellows also learn a lot at the evening or night time when they are relaxed. Thank you, sir. Professor Abdul Rahman, sir. Professor Abdul Wahid Chaudhary, sir. Professor Abdul Wahid Chaudhary, sir.
I think one of the beauty of this lecture is he did not make things complicated. From a very simple viewpoint, he started and then go into detailing what to do. And the technique of doing one step after the other, that's the way of doing things. You have to have a very clear idea what you want to do. And always when you want to do bifurcation stenting, particularly in left main, you should not do it at an ad hoc basis. It's better to have a very pre-planned arrangement of everything at hand so that you can actually go ahead without any complication. Thank you, Professor Tan Shahim. It's a very nice and detailed lecture, and it will be very helpful for the junior colleagues.
Thank you, sir. Thank you. One of the experienced operator and organizer, Professor Dr. Abdul Rahman, sir, with us. Please, sir. You like bifurcation always. You love bifurcation. Please, few comment regarding the lecture, sir.
Yes, Professor Tan, thank you. This is a very brilliant lecture, I would say that, because you pinpointed the thing rightly and you make the thing very simple. The way you are dealing, that's really appreciated. So I personally like the provisional stenting, and most of the time, if you think like you, like what you do, most of the bifurcation can be dealt with the provisional stenting, even 80 to 85% cases. So only 5 to 10% or 20% cases you need a double stenting strategy. And you have demonstrated that the several way of the double stenting strategy, either decay crash or mini crash or Culotte or tap technique, starting from the. But which technique you are comfortable? I think so. The operator should do that. If you are comfortable with decay crash, you should go for decay crash. If you are not comfortable with Culotte, you should not go for the Culotte. So starting of the Culotte maybe you cumbersome. Another thing you stress, you give the impression that imaging has a role, especially in the setting of the double stenting strategy. But provisional stenting strategy, I think so, because in our country it is very difficult to cope with the financial problem. Is very difficult. So IVUS or OCT and in all that bifurcation is very difficult. And the people like you can do the complicated process even with the without imaging. That's right. Suppose you are very expert. If I say that this is a decay crash, the left main, you should do it without imaging. Are you ready for do that or not? For you, not for me.
I could, but I prefer to use imaging.
Okay, that's right. That is the very and the recommendation is class 2A. So the expert like him, it can be done, but should be do with the imaging. And thank you, sir. Thank you for a great lecture.
Thank you, Professor Dr. Mir Jamaluddin, sir, Director NACBD, with us.
Thank you, Dr. Mohsin. Thank you, Professor Tan Hussein. Your lecture is, Professor Abdul Rahman sir has commented very nicely, and your lecture is excellent. And you have given the lecture simple case, complex case by simple way. That is the beauty of your lecture. So far, I have also noticed, and you have done it very simply. Different stages, tap, Culotte, decay crash, everything you have mentioned, whatever in the book or whatever in your practice. But we also do the bifurcation cases, but I do agree mostly agree with Professor Abdul Rahman sir. In most of the cases, we try to do provisional stenting. If not possible, we try to do tap, and if that is also not possible, then we try for decay crush. But Culotte is a bit cumbersome for me. I have done few cases, but I am not well oriented with Culotte. So I also like decay crush, and decay crush result is also good. And the imaging is also very essential, which is at least available in our institute by the Professor Abdul Rahman, who has given us this in our institute. Thank you all. Thank you, Professor Tanvi Sim, once again for your nice lecture.
Thank you. Professor Dr. Maunish Sijar. Professor Dr. Maunish.
First of all, thanks to Professor Tam for your brilliant lecture. With the previous comments of the Professor Abdul Rahman sir and Min Jamaluddin sir, that you present the complex thing in a very simple way. Regarding the bifurcation PCI, with your consensus, we also believe that the provisional stenting should be the choice. Around 80% of the bifurcation lesions can be treated by the provisional stenting technique. And regarding the if angle of the bifurcation is suitable, then tap we can be done. And like Mir Jamaluddin sir, we are not habituated so with the Culotte technique due to the crossing difficulties of the wire, and we did decay crush. And imaging is very helpful for the bifurcation lesion PCI. And you are correctly said that many of the bifurcation lesions can be treated by the provisional stenting if the imaging shows that with around you are showing that with the 75% stenosis of the ostium lesion, maybe the 20% only have the really significant lesion. So the imaging can be very helpful for determining the procedure of the bifurcation lesion. Thank you again, Tang, for your brilliant lecture. Thank you.
Professor Tan, I just would like to comment on the tips and tricks of Culotte technique, because I think a few operators are worried about Culotte technique. Few comments for the fellows or who are not accounted to Culotte technique. Please few comments on Culotte technique again.
Actually, I grew up learning a Culotte stent technique. So where then, because of familiarity, you become not so worried about it. I feel that the beauty of Culotte stent technique is that it ensures that the cover of the ostium of both the branches very well. But the biggest downside is that if the main vessel is much bigger than the side branch, then Culotte technique is really not a good choice, because your stents may not be able to expand fully in the main vessels. But otherwise, it's actually not as difficult as decay crush. Actually, I find decay crush more steps than a Culotte stent technique. A Culotte technique actually got 5 steps, but decay crush has got 10. But whether it's 5, 7, it really doesn't matter. Whatever techniques that you choose, you have to do it meticulously, and you have to carry out every step, whether in terms of passage of the wire into the side branch, through the distal cells or the proximal cell, optimizing the techniques, optimizing the stent deployment, doing proper kissing and ports and so forth. So whatever techniques that you use, as long as you do it meticulously, step by step, you will achieve the as good an outcome as anybody else.
Thank you, sir. Dr. Arun Maski is the Nepal, I think, faculty with us. Dr. Arun Maske, welcome to our session. Dr. Arun, Professor Arun, please, any comments or any question for the...
Oh, there's nothing to talk. Dr. Tan, your lecture was excellent. And you have given a lecture in such a simplified way. I think there's nothing much to ask to you. You are an expert. You are a good academician and teacher. I would like to thank from my colleagues from Nepal for training our young residents in Singapore. That's a great job you have done. And thank you, sir. Thank you for your lectures. So we hope you would be training our further a good number of residents. Thank you.
Thank you. Thank you. Dr. Khalid Bosi, sir, with us. Khalid Bosi, sir, please ask your question.
Yeah, thank you. Dr. Tan, for describing all the techniques in a very neutral manner without expressing your personal preference to any of the techniques. This is a very nice way of disseminating knowledge. Actually, I would like to ask you a question. Suppose in a situation of primary PTCA with a LAD D1 bifurcation 111 with an angle of about 65 degrees, what will be your preferred technique in a primary PCI situation, not in an elective situation?
In an emergency situations, I'm trying to save life. So
Yeah.
I'm not going for perfect results here. Provisional strategy will be my first choice, sir. If I can just keep the side branch open, I'm quite happy. I'm just deal with the LAD first.
So, no, if you have to use Two-Stent, what will be your strategy in a primary PCI?
In a angle that's 65, as you mentioned, it will either be a Culotte or a DK crush.
Would you attempt DK crush, which might be a bit time consuming in an emergency situation?
No. So I will go with something that I'm familiar with. So provisional followed by Culotte if necessary.
Thank you. Professor Shahabuddin Talukdar, sir, do you hear me? Please unmute yourself.
Professor Shahab,
Please
you have to unmute yourself, Shahab bhai. Yeah.
Okay, now?
Okay, yeah.
Can you hear me now?
Yeah.
Yes, yes.
Okay. Thank you very much, Dr. Tang, for your beautiful and enlightening presentation. Step-wise approach of a bifurcation lesion in a simple way. Many things have been discussed already of my colleagues, but I have one question regarding the distal start crossing. It's very important to prevent the protrusion of the start in the main vessel, prevent the endothelization and the occlusion, and shift of carina. What is your strategy you take, whether it is in the distal start or in the proximal start? One is eye estimation, or your angiographic view, or your IVUS study. What strategy, what option you take?
Rewiring the wire. Yeah.
Rewiring the second one, whether either in the distal start or proximal start, because it is very important.
Okay, sir. Okay, sir. Yeah.
So most of the time we will use angiogram to determine whether our wire is in the proximal on the distal cell. And I think most of the time angiogram would be able to give that information. However, if you are already having a OCT or an IVUS on the table right from the very beginning, certainly using it as an additional guide as to which position is your wire is even more helpful. But I would say that most of the time I would try to use angiographic guidance, and it's also by the techniques that I would employ. So I will shape the wire to go down to the main vessel first and then pull back to redirect into the side branch, instead of going straight away into the side branch where you may actually enter into the proximal cell. So by technique, by angiographic guidance, and perhaps by imaging guidance will be my order of steps in trying to achieve a distal cell passage.
One important, Dr. Purat Karki from Nepal, he was asking, when size of main branch, main vessel and side branch is not equal, can we still do Culotte by stenting the small vessel first?
So in that case, you have to make sure that the stent that you choose is able to be expanded to the size of the main vessel. So while the side branch may be, say, perhaps smaller, but this stent is capable of being expanded to a large diameter in the main vessel. So if the discrepancy is not so huge beyond the stretching capacity of the stent, then you can actually use a Culotte stent technique. And I'll have to say that most of the stent now can be extended really big. For example, if I use a cobalt chromium, I know that if I take a 2.5 stent, I can go up to 3.7, a trio stent can go up to 4.2. So really it has made life a lot easier for many of us now with this new design stance.
Another question is, what are the indications to stent side branch when doing provisional strategy? You have gone for the provisional strategy, but you have later decided that you have to do the side branch as well. What will be the conditions? The question was asked by another student.
So first of all, you have to decide on the indications first. So do you really need to intervene in the side branch, having already decided from the very beginning you want to do a provisional? So it must be a situations where there's severe ischemia going on in the side branch, or where you fear losing the side branch in that sort of situations. Once you have established the indications, then you can use a couple of techniques, again, depending on the anatomy. It could be a tap technique, which I would prefer. Given that the stent has already been put in, it's much easier, just a one-step procedure, followed by a kissing. Or you can, of course, go to your reverse crush and your Culotte technique, which will be a little bit more complicated. So by and large, I think when you have a stent that has been put into the main vessel and you're trying to intervene in the left main, if the anatomy permits, I would just do a simple tap technique. And this will be actually what the Europeans will recommend most of the time.
Dr. Tang, let us say there is a side branch, the site is around 2 millimeter, only ostial tight lesion. We go for provisional stenting, going for the main vessel stenting. Do you want to pre-dilate the side branch beforehand, as you fear there is a calcification, and after provisional stenting, you may not enter the ostium of the side branch? Do you want to do that?
In general, if you are doing a provisional strategy, we will not touch the side branch at all.
Exactly.
However, if you want to go by the first technique, which I recommended, that you want to keep the vessel open because it's so small. At the same time, I don't want to put in stent, but on the other hand, I don't want to lose it either. Then we can do things like what we call a gel balloon technique, where you just take the balloon, pack it by the side branch, inflate the stent in the main vessel, and then after that, use a main vessel, use a side branch balloon to inflate a little bit, and then you pull back the side branch balloon, and then you go high pressure on the main branch. In that case, you will always preserve the patency of the side branch vessel if you have no intention to put in stent at all.
Yeah.
Dr. Kaiser Nasrullah Khan. Dr. Kaiser Nasrullah Khan.
Assalamu alaikum and good afternoon to all. It was a splendid lecture by Tan Wichim, as usual. Learned a lot from you. And definitely bifurcation lesion is a challenge for everyone, be it left main, be it side branch. But my take is that keep it simple. Thank you.
Thank you. We go for the next two cases, sir. Do you permit, Dr. Pavitan? You see the two cases for the young cardiologists from Bangladesh. They are young budding cardiologists. Okay. Dr. Sharif Islam Ratan, please share your screen.
Please can share. Are you hearing me, sir?
Yes, you go.
Honorable chairpersons, honorable chairpersons, moderator, panelists, my teachers and colleagues, good afternoon. I am Shariful Islam, presenting the case. My case title is The Sailor in the Deep Sea. This is the brief clinical history. Mrs. X, non-diabetic, non-hypertensive, 70 years, female, presented with central chest pain, which corresponds to CCS class 3 for 12 hours and diagnosed as a case of unstable angina. On examination, patient is invasive test report shows biochemistry reveals normal and ECG changes non-specific HTT changes. Echo shows anterior local hypokinesia with LVA 48%. And this is the invasive test report. Invasive test report shows that this is the limb main by.
Do you skin large, please?
Lesion involving the distal limb main an osteoproximal LAD and LCX lesion having 80 to 90% stenosis.
এটা সাইজ বড় করো।
শরীফ সাইজ
Already discussed. This is the bifurcation classification.
সাইজটা বড় করো।
হ্যাঁ স্যার,
পাশের স্ক্রিনটা অফ করো।
দেখো,
অফ করো।
পাশের স্ক্রিনটা অফ করে দাও।
হ্যাঁ,
এটা অফ করো।
বড় করো।
এটা
হ্যাঁ, বড় করো।
অনেকগুলো স্লাইড একসাথে তো বড় হবে না মনে হয়।
না না, তুমি পাশেরটা ক্লোজ করো, ওই যে নেক্সট স্লাইডগুলো বন্ধ করে দাও।
হয়েছে হয়েছে।
ওকে ওকে, গো স্ট্রেট ফরওয়ার্ড।
হয়েছে, ইয়েস
হ্যাঁ যাও। ইয়া,
this is the bifurcation classification system. This is the Modena. Yes, this is the bifurcation classification system. This is the Modena classification already discussed by the Professor Tan. And this is the bifurcation PCI algorithm systems. And this is the double standard strategy involving the limb-mean bifurcation systems. From the above angiographic picture, now what to do? Now we keeping this view in mind. This is the Modena 111 classification. This is the diameter of the vessels, length of the lesions, angle of the vessels, and supplied area of the myocardium. We decided to two-stent strategy, and we choose for the decay crash. And this is the EuroPCR 7-step procedure of the decay crash. Now this is the coronary bed preparation by wiring and pre-dilatation by 2 into 10 size balloon at 10 atm pressure. And on the top of the right side indicates the numerical value of the steps of the decay crash. Inside the main vessel balloon at or distal to the origin of the side branch, and side branch stance was deployed. This is the crashing of the side branch stent. First rewiring and first catching balloon inflation. This is the deliver the main vessel stent. Stent size was 3 into 33 millimeter at 14 atm pressure. Then post dilatation was done of the male vessel, including first pot. Then second rewiring of the side branch through the main vessel stent and remove the side branch wire. And second kissing balloon inflation was done. And this is the final step of the decay crash, report. And this is my crash and this is your crash. The take-home message is that bifurcation lesion PCI is a complex procedure associated with more chance of re-stenosis and reinfection. If two-stent strategy is needed, decay crash provides a viable and data-driven option. 6 branch is compatible, more reliable final catching inflation, better side branch stance coverage, largely independent of angle. Decay crash is effective double stent strategy where carrying out the bifurcation will make. And this is the decay crash team. And thank you all.
Stop share.
Share stop.
Dr. Professor Tan, do you comment?
Yes, I was just looking at the decay crush technique. As you crush your first stent with the balloon, actually you don't have to pull out the wire from the side branch. You can leave the wire there as you crush the stent, because that wire will help you to guide your next wire going into the proximal cell of that crushed stent. So you don't have to worry about not being able to pull back the wire later on, because the amount of material, stent material, that is crushing on the side wire is actually very little. So you don't have to worry about that. So just leave the wire there after you have crushed with the balloon, and then use the next wire to go down with the first wire as a guide.
Any comment, Dr. Arun Maske? Arun Maske, the comment?
After getting expert comment from Professor Tam, there's nothing to comment. Yeah, it's good. Whatever you've done is good. And only is in our setting, like if you're doing in Western country, you do with IVUS. And our setting, we do not do with IVUS. My question to Tom is how comfortable would he be doing this sort of bifurcation lesions without any imaging techniques? If you think angiography good, are you comfortable?
Rightly questioned, sir. Without imaging possible decay crash, usually you do the all left main decay crash. It's possible on imaging or IVUS or OCT, sir. Professor Ten.
I think it's possible. It's just that you will have to. You can even use QCA on the on your machine software to measure. Otherwise, I think in an experienced operator, visual estimate can be pretty good as well. But we tend to be a little bit more conservative in the visual estimate. So perhaps you want to make sure that you choose a balloon, particularly in the main vessel, to be sized at least 2/3 of the sum of the diameter of the two daughter vessels. So you want to have a good sized balloon in the proximal parent vessel for a final port when you do a decay crush technique. But otherwise, I feel that imaging is not 100% needed. In an experienced operator, you could possibly do it as well.
Thank you, sir.
I would say that some proctoring will be very helpful if you are doing it for the first time. Maybe work with somebody senior if you don't have image to guide you.
Thank you. Professor Dr. Fazila Malik with us. Madam, welcome.
Yes.
Yeah.
Hi, Fazila.
Hi, how are you?
Very fine, thank you.
Singapore looks really good. I mean, you're all dressed up and dapper and gave a great lecture. So congratulations on a great presentation. I'm sorry I got a bit delayed, got stuck with the case, but that was a very good observation that you said that imaging is not absolutely mandatory. Yes, because in Bangladesh also, like, imaging is an issue because it is expensive, and in many centers imaging is not very readily available. So I mean, the imaging is great, but if you don't have it, it should not limit an experienced operator, as you rightly pointed out. Yes.
Yes.
So any plans of coming to visit Bangladesh once the COVID situation resolves a bit?
Yes, I look forward to that.
Yeah, well, and we invite you, and it's great that we can see you virtually. So thank you for coming at least virtually to Bangladesh. We really appreciate that. Thank you.
It's a tremendous pleasure to be able to see so many friends as well.
Right.
Thank you. Yeah.
Thank you.
Thank you.
We go for next case, Dr. Mahmoud Hassan Khan. Please go to the next case. Yeah. You go to the first slide. Yeah.
Thank you, sir. Honorable Chairperson, my teachers, learned panelists, Assalamu alaikum, and a very good afternoon. I am Dr. Mahmoud Hassan Khan. On behalf of Department of Clinical and Interventional Cardiology, Evercare Hospital, Dhaka, I am presenting a case on complex bifurcation PCI. Our patient, 67 years old, hypertensive female, admitted and treated as a case of non-ST elevation, ACS. She has history of PCI to LAD in 2006 and 2014. Her ECG showed OLMI anterior and echo showed with a regional wall motion abnormality, ejection fraction was 40%. Relux ECG done in our center showed she had double vessel coronary artery disease involving the distal left main. syntax scoring done, it was shown that syntax 1 was 34 and syntax 2 preferred treatment of treatment modality was CABG. As per 2018 ESC guideline for myocardial revascularization, left main coronary artery disease with high syntax score, CABG is preferred one, that is class 1A. Patient and family were not keen on undergoing CABG, opted for multivessel PCI. As we know, the Medina classification for bifurcation lesion, a true bifurcation involves both the main and side branches. As you can see, our patient, according to Medina classification, has 110. So what will be the strategy? Provisional stenting using a single stent or a two-stent approach? Coronary bifurcation PCI algorithmic approach, we all know that if the side branch needs to be preserved, likelihood of then we need to consider the likelihood of side branch occlusion. If it is high, then plan two-stent strategy. If low, then provisional side branch stenting. So we opted for a single stent approach for this lesion. Preferred choice of technique was provisional single stent technique. These were the hardwares used. So initially the wiring and pre-dilatation of the main branch and side branch. Then we have done the IVUS. Then the positioning of the main branch stent from left main ostium to LED. Deployment of main branch stent was done. Now the ostium of the circumflex, mean significant rewiring of the side branch through main branch stent. Pre-dilatation was done. After pre-dilatation, there was still significant pinching of the ostium. Another IVUS run was made and it showed the significant ostial pinching of SARC. Pre-dilatation of SARC ostium continues. Kissing will done. Still we tried to open the strut and dilate the SARC ostium. POT being done. After POT, still there was significant pinching. Another IVUS run being done, and it also showed that there was significant pinching after POT. So we decided for a second stent in SARC. Positioning of the SARC stent was been done. Then circumflex stent been deployed. Kissing done. After kissing, there was a report. After report, it's quite eye-soothing. Final IVUS run being made, which showed good stent apposition with no malapposition of stent struts. This is the final scene, which showed timid distal flow with good revascularization. So what study says? Cardiovascular outcomes associated with crush versus provisional stenting techniques for bifurcation lesion, a systemic review and meta-analysis, they showed in patients with coronary bifurcation lesions undergoing PCI, crush stenting technique was associated with significantly lower major adverse cardiac events and repeated revascularization without any change in mortality, myocardial infarction, and stent thrombosis when compared to provisional technique showing a benefit of crush over the provisional stenting technique during PCI. Comparing two-stent technique versus provisional stenting technique in bifurcation coronary artery lesion, they showed in developing countries with limited resources, the strategy of desimplantation in the main branch with provisional stenting of the side branch for the treatment of bifurcation lesions should be the preferred strategy. And final kissing balloon post-dilatation is mandatory when using a two-stent strategy, provides significant reduction in main branch and side branch restenosis, must be performed optimally using appropriately sized balloons, sequential high-pressure balloon dilatation of the side branch stent, then the main branch stent, finalized with lower pressure kissing balloon dilatation. So my take-home message is single stent strategy appears to be less complicated. Try to keep the procedure simple. There should be a plan B and try to keep your head cool. Every approach is overlapped with each other. According to situation, single stent approach can be turned into a two-stent strategy. POT and FKBI are essential. IVUS guidance is mandatory when treating complex left main and non-left main bifurcation lesions. IVUS guidance leads to a lower MACE rates, lead to decreased rate of stent thrombosis and target lesion revascularization. Thank you all. Thank you for your patience hearing.
Thank you. Thank you, Mahmood. Excellent case. Professor Tan, did you comment?
The narrowing of the ostium of the circumflex come as a surprise to you?
It was shocking. It was shocking because the ostium procedure, the ostium of SARC was so healthy, and it, we didn't even think of going for a two-stent strategy. Straightforward, we planned for a single-stent strategy. But when we inflate the stent in the main branch, the SARC ostium, we just shocked and said, "Oh my God, what's going on?"
Could it be just a carina shift?
Yeah. Carina shift, it may be, but probably my operator decided that it may be due to the distal left main plaque shifting to SARC ostium.
Sir, I have a question, sir. The IVUS, how you determine that is plaque shift or carina shift? I think this IVUS shows the carina shift in the different views. I think you see carina shift. If carina shift, don't bother about the another stent. You comment, sir.
Yes, so if there's no obvious, because if you do IVUS, you would have seen the anatomy and the plaque location from the very beginning. And if your plaque locations is on the opposite side of the vessel, which is most of the time from the origin of side branch, it is very unlikely that it's the plaque shift that causes a narrowing of the lumen. Oftentimes, as we know, is really from a carina shift. When you start doing POT in the proximal vessel, it always looks like that. And if you do a FFR down the side branch, you'll find that actually it's not so worrisome. And so if you don't have a FFR, then I would look at the patients carefully and see whether there's symptom of ischemia and so forth. But you have made the call that this is significant based on the angiogram and deal with it nicely. I think it's a reasonable one because circumflex is a huge vessel in your case, and we just can't afford to lose it if it's fully ischemic. Everywhere else, I might just leave it alone, but because this is a big bifurcation, I will be very cautious to leave it alone.
Thank you, sir. Professor Mamun Rashid, sir, do you comment?
And regarding this case, the FFR is mandatory for doing to see the ischemia of the sharks.
Not mandatory, but if you have it, it will help you to make a decision as to whether this is true plug shift causing narrowing or it's just a carina shift, and in which case I don't have to do anything about it. So if you have a pressure wire, that will be excellent. But if not, if you can do a proper good job of doing a two-stand technique, because this is a big bifurcation, just go ahead and do it. I wouldn't be fighting with you or something like that.
If FFR is available, then FFR should be done. It will be good decision. You can.
That will be evidence-based. Yes.
Oh, thank you.
Professor Jamal, sir, do you comment, sir?
Thank you. I am on the way of another case, and that is why my mask is here. I do not know whether you are hearing me or not. Are you hearing?
We are hearing. Yeah.
Okay, thank you. It's a nice case, but I do agree with Tan. This case, if available, there is FFR. FFR wire could be done, and FFR should be done. And with FFR, I think it is not essential to do another stent. If there is TIMI 3 flow, there is no significant narrowing of the ostium, and FFR will give the result whether second stent will be necessary or not. If it is not available in the lab at that time, then a two-stent strategy can be done, and case is nicely done. Excellent job. Thank you.
Professor Shahabuddin Talukdar.
Thank you very much. Thank you, everybody. I am the operator of this patient. Actually, after putting the first stent, patient was become very symptomatic, hypertension, and this pain, so we don't bother for putting the second stent. Clinical assessment is the best assessment. Forget about our physiology. First, you assess the patient clinically on the drug. So we immediately take the patient for second stent.
Yes, you are very right.
And after putting second stent, patient become asymptomatic and nicely recovered. And
Professor Abdul sir.
That's what actually Professor Tanhwechi assess the patient clinically. If the
patient is being fine,
then do FFR. If the patient is unstable, that means you don't have to do FFR. You know that there is something critical wrong. You have to go for two-step.
Forget about physiology. First, assess the patient clinically.
Right, very right.
Right. Professor Abdul sir, do you hear me? Professor Abdul sir. Dr. Arifur Rahman, I think any question left in the chat box? Dr. Arifur Rahman, Shajol.
Thank you, sir.
Yeah.
First, I'd like to thank Professor Tanhwechi, sir. It has been a very great lecture and we have learned a lot. There are lots of questions. I am asking a few of them according to importance, sir.
Yes. Okay. Arif?
Sir, I am preparing, sir. Sir, there is a question asked by Abdullah Manjur.
Yeah.
In case of decay crash, rewiring through distal strut, and in case of provisional, proximal strut is preferable. Is it? Do you prefer this statement?
Oh no. So I think for decay crash, we will prefer a proximal or mid cell entry. Anything else, we will go for a distal cell like a provisional strategy. So only for decay crash do we go for proximal and mid cell approach.
Nice. Proximal and mid for decay crash. Thank you. Arif, next question.
So decay crash, you prefer for the proximal crash. Thank you, sir, for the information. Another question from Lieutenant Colonel Nizam. He mentioned there is a chance of thrombus formation in case of tap technique due to proximal protrusion. How far you face this situation?
Actually, there has been quite a number of studies comparing the risk of stent thrombosis between provisional and two-stent. And actually, there have been no difference found if the techniques is properly performed and carried out. So I don't think that there is an increased risk of stent thrombosis with a two-stent if you do it well.
After the case, the chances of a significant protrusion doesn't actually arise. You are actually smoothing out the orifices, making it more circular.
I think this process happens mostly when we use the old hardware.
Yeah.
There is a question from Charan Singh from BSMMU. He wanted to know about the imaging technique. About the imaging technique, you mentioned if there is no chance or availability of imaging technique, whether we should go for bifurcation procedures or not, or there is implication of outcome of the success rate.
I think we said before, if there's no imaging equipment available, you can still go ahead and do your PCI, but you will want to make sure that you have a good high pressure balloon inflation to make sure that the stent is fully expanded and you will observe every step carefully. I don't think the absence of any imaging modality precludes the performance of a bifurcation PCI.
Thank you, sir. It will be of great help for the beginners. There's a question from Tanvir Ahmed from United Hospital. He wanted to know if he planned for decay crash and we failed to recross the wire. In that situation, which bailout procedure you prefer?
So after decay crash, you can't cross into the side branch again?
Yeah.
In the first crossing or the second crossing?
Sir, the first crossing, first crossing, sir.
Actually, 100% of the time you can cross, sir. That's, so that's the beauty of decay crash. Take your time, do it slowly, you will be able to cross it. In a classic crash, 10%, no matter how hard you try, you will not be able to do it. But in a decay crash, you will be able to do it. So take your time and find the,
I think lots of question for the juniors. We are passing about 2 hours time. Please observe one for our last comments from you. This program and last program for junior colleagues.
No, thank you very much. This is really good session, I think so, and Tan giving a lot of instruction. But we want to see in Tan in person. So hoping to see you in February 5, 6, and 7. I think so. It is in your schedule. So at the time, COVID will be solved. So I think so that will be the first international conference after that in COVID. I think so. So thank you, Tan. Thank you very much.
Thank you, sir.
ধন্যবাদ ভালো থাকবেন আপনাদের বর্ডার খুলবে কবে when your border open sir
I learned something.
Okay.
Professor Tan, your comments for the fellows and junior fellows that doing the cath labs in the safe procedure, and they should skill knowledge before doing the complicated case. Thank you. Your comments, sir. Yeah.
I think this is an excellent learning sessions for you to be able to be exposed to some of the insights from many of the experts here. I think that is a good start for you to learn. And after which I would encourage you to go through again the slides and the videos and so forth, and have it in your mind the steps that you will need to take in assessing the bifurcation lesion, what sort of a technique to do, and if there's a technique that I want to do, what are the steps involved and so forth. So go through your mind. If you can get hold of a model to work on it, that'll be better. But otherwise, talk to your colleagues, learn from your teachers and so forth. Master one two-stent techniques first before you go on to another one, and then do it step by step in a graduated fashion. I think you will find that bifurcation PCI is not that difficult after all. So thank you very much.
Thank you, sir. We are grateful to you for your presence. We are lots of time giving to for the us and also junior fellows. I think they are enriched your knowledge, and if this you lecture in the IPDR archive, they can go through this lecture repeatedly. I think they will be benefited. Thank you, Professor Wadud, sir. You conclude the session. Wadud, sir.
Professor Tanvir Chim has given an excellent lecture. Everybody is saying that, and everybody is saying it will be helpful to the fellows. But I do think it will be actually also helpful for us as well, because the level of expertise he has acquired and the level of expertise we aspire to, there's always room for improvement. We'll be doing that by going through this lecture ourselves and using the knowledge that we acquire from the discussion we had. But most important thing, I think, is that we always should have a very clear idea of what I want, what I can do. And we should be always have a clear idea of our own limitation, whether I am the operator who can do this particular case. There are bifurcation and there are bifurcation. Some everybody can do, some very few experts can dare to do. And that demarcation, that understanding actually comes with the knowledge. And today's lecture is a very good step in that. And we are going to have clear idea how to do a bifurcation lesion, which sort of bifurcation technique we are going to do, and then plan accordingly. Professor Tanhuichim, we are really grateful to you. And we do hope we'll be getting you again and again in different way, in different academic fora. We'll be getting and we will be sharing your knowledge with us. Thank you, sir.
Thank you very much. Thank you, everybody, especially Professor Ten. I also thank Beximco Pharma. They are a lot of trouble last 3 months with us for technical support. Also, I acknowledged Abbott Vascular. They also with us. And thank you, Professor Abdul Rahman, sir, for your busy schedule with us. And Arun Maske from the Nepal. Also, Khalid Mohsin, sir, Professor Abdul Wadud, sir, Dr. Arif. Thank you, everybody. Professor Ten, as Wadud sir said, you will come again in the virtual class if you ask you if you have enough time. Please give another lecture. I think you next month or 2 month. I will ask you send a letter. If you feel free, give another lecture. Thank you, sir. Thank you. Thank you again. Thank you.
Dharma and Deka Hobe.
Deka Hobe, inshallah.
Deka Hobe. Thank you, sir. Thank you, sir.
Thank you, everybody. Assalamu alaikum.
Bye-bye.
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 Thank you, sir.
Thank you.